I've just added the agenda to the chat. Thank you for adding that to the team for adding that to the eBite, so everybody has it immediately available. Gary, when I look, I see that we have about 7 people. I know that we're also at the top of the hour. Do we want to give ourselves another couple minutes? What do you think?
We can do that. I do expect that Hallie, he did accept. Katie, I met with yesterday. I know that she's aware of the meeting. Mateo Pearson will not be in attendance. He does have numerous grants, and so we won't be seeing Mateo today. So yeah, a couple more minutes would be just fine.
Okay, thank you. Actually, maybe what we could just do is start to do some of the more social aspects that are the community building parts, so that as people join, then obviously that's going to, building community is always going to be very, very important, but that versus like the business part of it, if you will. So we could maybe just start with that. How does that sound?
That sounds great.
Okay, thank you. Thank you. You are so flexible. Thank you. So team, if your camera is off, maybe you're driving, maybe you're multitasking, probably that you are. This is Eileen, and thank you everybody for joining us. Please do whatever you need to do to be safe. I do know that some of you might be driving, or maybe you're taking care of kiddos or something, so if your camera off, that is okay, we welcome you. If when your name comes up, then would love if you would be able to introduce yourself, and we will, I'd like everybody to refer to each other by our first names, because not everybody here is a doctor, but everybody here is valued, and everybody here is valued. And maybe I'll ask people to say what is, they can say their name, they can say where they're calling from today, and maybe if you could also say if you prefer the Isotopes or New Mexico United, or if you have a different hometown team that you love and would love to hear that. So I'll go in the order that I can see, and maybe we'll start with Rosanna, if you're able to introduce yourself.
My name is Rosanna Archuleta, and I'm the manager of the patient services here at the medical cannabis program. And yeah, I guess New Mexico United.
Okay, I like it. Thanks. You didn't seem super convinced, but that's okay. I appreciate that you went with it. And next, Kathy.
Hi, good morning, everyone. I'm Kathy Adjeri. I am the IT project manager supporting the medical cannabis program, calling in from Albuquerque today. A different location. If those of you have seen my background before, this is new for me. And I would say, yeah, I'm going to go with Rose. I like a good football game, so United.
Oh, nice. Okay, I like it. And you said football, which makes me also think that you're a Ted Lasso fan, but I won't put you on the spot about that.
I am. Thank you, Andrea.
Nice. Thank you. Diego?
Hi, my name is Diego Diaguero. I'm the future health educator for the medical cannabis program, calling in from Santa Fe. And my sports team would be probably the New Mexico State Aggies.
Okay, nice. Thank you. And Eleni.
Hi, good morning, everyone. I'm Eleni Bukovalis. I'm an emergency physician calling in from Placitas. No strong sports opinions. No.
And that is okay too. It is okay if it has to do with maybe like a large ball and little kids trying to learn how to catch. That's okay too. and learning how to kick. That's perfect as well. Thank you. Gary?
I would have to say the United. I used to play soccer as a kid and still enjoy watching it. So, and I'm calling in from Santa Fe.
Wonderful. Thanks. Howie?
I can't tell if I'm muted or not muted.
We can hear you and we can see you as well. Nice to see you.
Thanks. Hallie Faust from Santa Fe, and I must say that after last night's win, I'm still a UConn fan. I moved to Santa Fe from Connecticut after 20 years, and disappointed that the ladies didn't beat Iowa.
Me too.
earlier, but that could have been a great women's and men's overall defeat of the other teams, obviously, but an overall win, I should say. But anyhow, we'll take the win last night. Very definitive.
Okay. Congratulations and thanks. Crystal. Oh, Crystal, you just got super soft.
Did I? Is that better?
Oh, a little bit better. Yeah, thank you.
Okay. Calling in from a particularly noisy flying star. I think I would do isotopes.
All right. Okay. It's a good choice. I particularly love that they have the chili versus the green chili, red chili versus the taco race. I mean, who doesn't love that? And salsa, I think, also too. Thanks. Brenda?
Good morning, everyone. Brenda Martinez. I'm with the Medical Cannabis Program, staff manager, calling in from Santa Fe, and I would say UNM Lobo basketball, particularly the men's team, did really well this year. So
yeah, I was wondering when someone was going to mention them. Oh, go ahead, please.
That's it.
Oh, okay, thank you. I'm sorry I interrupted. There's somebody who's listed as meeting guest, and I'm not sure who they are. So maybe actually what we'll do is we'll circle back to you so you'll know when you don't hear your name coming up from other people. So next, Selena.
Hi, I'm Selena Montoya from the Medical Cannabis Program here in Santa Fe. And I'd have to go with Brenda, UNM.
Nice. And Haley?
Morning, everyone. I'm Haley Peterson. I'm with the Substance Use Epidemiology section here at Department of Health, calling in from Albuquerque. And I'm also a huge Lobo basketball fan. I have season tickets to the men's games. It's really fun, great environment. So I'm all about it.
Oh, fantastic. Thanks. Andrea, or I should know, Andrea, please correct me.
I don't have a preference. So my dad called me Andrea. My mom called me Andrea. So I'm just like, whatever. I don't care what people call me. Good morning, everybody. Andrea Sundberg. I'm the acting director for the Medical Cannabis Program, calling from Santa Fe. I have to admit, I have not gotten into teams. I am getting more interested in football. So I do want to go to a United game, but my team is the Cleveland Guardians. I'm a huge Guardians fan. So, and they don't stink this year so far. So, we'll take it, even though it's always a rebuilding year in Cleveland. So, but I still love them. So, but that's my team, and I have not even made it to an Isotopes game.
Okay, no judgment. It's okay, no judgment.
I'm judging myself for that one.
Okay, well, I haven't been to a Cleveland game, so we're there.
Okay, there you go.
Okay, thank you. And there's someone who had joined with I believe, a phone number that starts with a 5 and ends with an 07, and all the others are X'd out. Who is that?
I believe that's Alan Plymel.
Oh, okay. Alan, are you able to? Are we able to? Maybe you're not able to unmute yourself. Okay. Or we aren't able to hear you. So I hope that works out in the future.
Sorry.
Oh, there you go.
I'm sorry, my not letting me.
Oh, just lost you again. Oh, Alan, we aren't able to hear you. Do you want to try one more time?
How about now?
Yes, perfect. Thank you.
Oh, okay. It says I'm muted right now, so it's backwards. But anyway, we're having a beautiful day in Deming, and wish everybody a nice day. And I'm kind of a UNM grad from years ago, and so I lean towards the Lobos.
Okay, always a good choice. And then there's somebody whose number is who is listed as meeting guest. Is there anybody who is on who we didn't get to hear from? You didn't hear your name. And if so, if you would unmute yourself, so introduce yourself. Okay, I'm not sure who that is yet. And if you're speaking, we can't hear you. Yeah, but you can always put it into the chat. So thanks everybody for going with it. Amazing to me that also people are willing to go with it this long into the work. Thank you. And with that, we'll turn it over and would next like to hear an update from the medical cannabis program, and I will be muting myself.
All right, thank you. Before I start though, we're going to go ahead and introduce Diego. I had asked him to join today's meeting. He hasn't quite started in the role of the health educator, but that will be coming shortly. But we did feel it'd be a great opportunity, since we don't know when we'll be having a next meeting, to have him join us and sort of be a fly on the wall so he can get to know us. And of course, we've got to know him now as well with regards to the icebreaker there. So welcome, Diego, and we'll you know what I'm about to do, Diego will probably be doing next time, and that's going to be providing you an update with regards to the recent statistics about the program. So let me go ahead and share. And again, this is just a small update. Okay. So again, we are here in the meeting today. And here is our March data. We do again publish all of this data. It is available on our webpage. And so all of this can be found there, but I do think it's always good to sort of keep our eye on some of these stats as we meet. So again, we are at 81,517 enrolled patients in the program, and that is as of the end of March. And again, these are the three most qualifying conditions. Those have not changed: PTSD, severe chronic pain, and cancer. And if we look at the enrollees by age, again, we still see that pretty even spread, more even than I would have expected previously, but it's still, these numbers are rather consistent, remained pretty much the same as from our last meeting. And here is that data in chart form. And you can see that percentage-wise, all of these groups are at around 15 to 19%. And so, and again, if you can't see this down here, the 71 plus, 13.54% of our individuals are elderly patients. So again, as we go through these themes and these sections, we want to keep our eye on that population there. And of course, our youngsters as well, since so many of what we've been tasked with reporting on does affect that age group. So that's all I have to share with regards to the statistics. I did want to go to the SharePoint site now. And again, some of you have I've had the opportunity of speaking to in either the small groups or as a sidebar. But for those of you that have not had the opportunities to see this, I did want to share with you down here in the bottom of the SharePoint, and thanks to Kathy, helped spearhead this. She's a great organizer. We have an annual report schedule here. We thought it was important to sort of really flesh out the dates when things should be due. And so I'm going to go ahead and open this up. And what I'm going to do is go to the end, actually, because I know that we sort of thought, okay, well, December 2024, that's so far off, and there's ample time to really get things together, to get the content down. But when we started thinking about the dates, December 1st comes right after the Thanksgiving holiday. So actually getting information, and December 1st is actually a Sunday. So it would be that Thanksgiving weekend would be the weekend before. So actually we're going to have to get the document to Ariel Lamb, who is our liaison with the legislature, probably by November 22nd. So really that 12/1 date, we need to push back a little bit. And then when we submit it to the secretary for review, we want to give about 2 weeks there. Probably, we need to, 11/8 now is our sort of completion date. And then when we add the comms team, policy and accountability, and, review by the medical cannabis program, we're looking in October, really. So again, I think that we need to sort of, refocus or reframe how we view, when we need to really have this report completed. So, and again, if we do a final review, put about 2 weeks before then, we're looking at maybe September 20th or late September. And so what we did is we went back from here, and we went back like a week here for each one of these groups. Again, Eileen and Haley are going to be, are going to be reviewing and editing, and we don't want to barrage them with 8 different sections all at once. And so we wanted to stagger the completion for these groups so that there would be ample time for review and for feedback, and to incorporate that feedback as well. And so, and again, we have a little percent completion tab over here, and I'll probably be filling this in a little bit because a number of the small groups, we've met a couple of times and we have made some progress with regards to, number one, the talking points that the groups want to address. And so again, we've entered the talking points here that were sort of fleshed out during the meetings, and sort of who would be addressing those. And we'll be adding some of those talking points as well. I had a great meeting yesterday with Crystal and Katie. I don't see Katie here today, but I'll go ahead and share what some of the conversation was about. But Hallie suggested that we have somebody from each one of those small groups sort of act as maybe a spokesperson, just sort of to give that update when we have these meetings so that we can understand what those talking points are that one wants to, that the groups want to address. And so for the child access group, Crystal and Lenny, Haley and I had a great meeting. I want to say it was March 29th or so. It was at the end of the month there. And I believe, Crystal, you were going to sort of provide us a little bit of an update with regards to the group here. And again, yeah, I'll get to that other part later. If you ever want to sort of see how the groups are developing, though, you can go to the SharePoint. You could go to, you know, the individual folders, and I'll talk a little bit more about that. But let's go ahead and Crystal, sorry for the interruption. I'll go ahead and let you
No problem at all. Am I loud enough, Gary?
Yes.
Yes, Ellie. Okay. So Eleni and I, and then of course Haley and Gary helping us with this. But so we're doing child access, and we have broken it down kind of into 3 areas to make sure that we cover the breadth of it. So exposure during pregnancy and lactation, and then exposure to children. And so I think we're doing that up until age 11. And then from age 11 on, that will be exposure to preteens and teens, and we're going to put that together in one section. Our data is coming from, let me get my right thing here. We're getting, of course, looking at the PRAMS data, Poison Center, and then ED data. And Eleni has done a lot of work already on her sections. Her partner, which is me, a little bit of a slacker, but we're going to get there before our deadline. And that's kind of where we are with child access.
Yeah. So again, what I'm simply
Feel free to
highlighting,
jump in if I missed anything. Yeah.
Yeah. So what I did is I just went into the folder for child access, and here is where some of that content is being written. I'll go ahead and share this now. That one thing that I found is that we sort of just had a Word document holding these titles or these sections, but really what we needed is a folder, because as we drag in articles and drag in emergency room data and emergency room reports, we really did need to have folders here. So each one of these are folders now, and as you can see here, this is ED information that Haley provided to us. And then this is a trends presentation from a previous presentation from Haley. So thank you, Crystal.
And then thank you. Yeah. And thank you, Haley, for clarifying. PRAMS is the, yes, Pregnancy Risk Assessment Monitoring System.
Great. So our second group would be the road safety. And Alan, are you able to update us a little bit about the talking points for road safety?
I'm hearing most of it okay.
Okay. Well, I'll go ahead and share. Alan, I and Matthew Clark had a meeting, and then more recently, Alan and I had one as well. And I think that Alan's done quite a bit of work and research on the field testing question with regards to driver safety. And again, there is some content there that Alan has added to the Word document. And since we're having trouble connecting with him today, I'll just go ahead and share that that's sort of what that group was focusing on. Hadn't really decided a second talking point. Again, this might be ample, just really fleshing out, the difficulty with field testing, the difficulty or what products are out there, and if there are any products out there that would act as, impediments to people using and driving. So that sort of was what the focus was of that group there. Workplace safety, we met as well and did talk about workplace safety. Hadn't quite fleshed out a talking point, but one thing that seemed to be rather prevalent was defining what a safety sensitive position is. And again, I think that's apropos given that there was some recent legislation that was actually submitted. It didn't actually make it to the floor with an attempt to try to actually define what is a safety sensitive position, and even more, directly, how long before going to work is a safe time frame. So those were some of the discussion or talking points that this group was talking about. And of course, if others have insights that they feel a group would want to entertain, by all means, there's no reason why you can't bring that up as a committee member and share it with that team. The next group is emergency room visits, and Mateo and Matthew are not here. I'm just going to go ahead to go to that groups, because so much of this, Haley has been really instrumental in providing the ER data. She has access to the syndromic surveillance, and it's going to be from there that we obtain the ER data. Now, what's interesting is I did a presentation about cannabis hyperemesis, and so, Haley and I were able to interface and actually sort of look at, ER visits associated with cannabis, but also associated with nausea, vomiting, and cyclical vomiting. So again, I don't think that an actual talking point has been determined, but I think that, Eleni, when there's an opportunity, when we can get Mateo and Matthew together, what data from these ED visits, from the syndromic surveillance, would be salient for the report? Is it simply total number? Is it total number for specific age groups? Because Haley did also present us some expanded ER data that will show ER visits by age. What was interesting is the total number of cannabis-related visits seems to have been rather level since about 2021. I can go to that. Here we go. And so that was rather interesting. It wasn't quite as dramatic. So there might be some other variables that we want to include. Or, here's a graph by age. And here's the annual data. So again, the total number, and then here, the total number per 10,000 visits. And I think we have COVID here, which of course raised the whole number of ED visits. And then the number of ED visits has gone down, and the percentage of cannabis related has actually gone down as well. So I think we just need to decide what variables we would like Haley to sort of, look at for us. And then probably we won't have time for the 2024 complete data for the report, given, sort of our revised time frame, but definitely the 2023 is stuff that could be utilized. And again, when that group meets again, just sort of hone down on maybe what it is, or if the group as a whole, what you feel would be the most important part of ED visits to present. Eileen.
Oh, I certainly didn't mean to interrupt your sentence. I found myself really compelled by thinking about what is the outcome that we're trying to achieve. And one of the things that we've been talking a lot about has to do with, and that I think could get broad support, would be the idea of just child access. And so with that in mind, I'm curious people's thoughts, and we don't have to get into it now, about just making the distinction for ED visits between children and adults, because in an ideal world, with enough processes, structure, and education, we might be able to really limit those really make a dent, even if there aren't a whole lot of them. Children shouldn't have to be in ERs, right? So that is something that I'm wondering about.
Yeah, no, absolutely. And again, that's what this forum is for, we don't have to isolate just the small group individuals to make the determination here. So, and I think that your sentiment would definitely be echoed by, and Eleni.
Yeah, I was just going to say, I think that that's a very important point, Eileen. And I think that it's interesting because the child access group actually sort of overlaps a little bit with the emergency department visits and also with the poison center calls as well. And so when Crystal and I were speaking, like I was thinking that some of the like the section of child access that's the younger children, the under 11 children, and like accidental exposures, poisonings, basically, is really most of that data is really going to come from the emergency department and poison center data. So I don't know if it's sort of, given the way the report has been requested to be structured, if it's more valuable to break them out into that section. Like that was sort of what I had in mind in terms of organizing the data. But I think as long as that information is there somewhere, I agree. I think it's really important for us to focus specifically on accidental exposures for children, because they, we don't want them in the ED. We don't want their parents having to call poison center.
Great. I think Andrea.
Yeah, and one thing I will say is I know for the legislature, that is a huge issue that they do want to know about, is how many kids are having to access medical care as a result of getting access to cannabis. So, we have all these categories that we have to report on, but I would say child access and the public safety part are the two that they're really concerned about.
And Eileen.
Thank you. Hearing that from Andrea and also from you, Eleni, what I wonder about is, I don't want anybody to do needless work, right? But thinking of what is if our goal is documentation, which is important. Also, if our goal is to end up with to sort of put out the breadcrumbs and lay the path for something to change, something that's big enough to matter and small enough to win. And then hearing particularly the part about public safety and child access, I would really wonder about having a common thread as much as possible throughout every report, every subgroup being about trying to touch upon both of those two, with the goal being that then it sort of like leads people toward the many different reasons for why we have the recommendations that we have, or that we are creating such an obvious case that it almost persuades. The act of looking at the report is an act of persuasion for the reader. I'm curious people's thoughts on that.
I think the common thread definitely is going to make it a more cohesive report. And though there are, other threads that can be woven in, there's ample time to include those in future years. And again, what makes the headlines typically are these pediatric issues and exposures. And I thought what's interesting too, and we might want to, we talk about the percentage of ED visits, but there's that important part of outcomes as well. So there could be definitely some powerful stories with regards to outcomes that could really bring the point home as well. So it's interesting that there's the hard data of percentage and visits, but we can tie in the outcomes section also.
So I can best understand this outcomes by that. When you said powerful, I often think of stories as being really persuasive. Is that what you mean, as combining sort of narratives, vignettes, that sort of thing, separate from like X% were admitted? Oh yeah, vignettes. Yeah, that is the way we all think we're persuaded by data, but it's all the stories, right, that change us. So thank you.
And from a program perspective, we'll actually take this report and we can turn it into work that we're going to do. So like, if we find out about child access, like, do we as an agency need to invest in handing out child-proof baggage or packages, that we can give to people so they could store their product in it and the kids wouldn't be able to access it, so that's the ultimate goal. Is we can, when we identify an issue, we can then go to the legislature and say, hey, you can give us some money from the slush fund to do this project. And we could help address this issue. And then we'll track that data to see if it actually goes down. So that's what our goal is, like, to get an idea of what's going on and what do we need to do to help correct some of these issues.
Yeah. Haley, did you want to clarify? I think I might have misspoken about some of the data where you received that. I just want to, I see what you noted in the chat there and wanted to let you respond.
Yeah, thanks, Gary. And that's probably on me for it. It ends up in the footnotes of all the data spreadsheets, but I don't know if it always, is at the forefront for people. And so the annual files of data that I have that were broken down by age group and all that comes directly from the Essence platform. And so when it's pulled directly from Essence, I'm using the syndrome definition that they have, which looks at both the diagnosis codes and some text analysis of the chief complaint field. And so it's going to pull in more visits because it's doing that text analysis for one thing, but also because the Essence platform just has tons of data that's coming into it. And for the hyperemesis data, that's coming from, it's still coming from syndromic surveillance. So it's still similar in that sense. But when I look at it for specific like diagnosis codes of, visits related to cannabis for certain things, I'm using data that I've processed. So I've taken it through a statistical analysis program to pull out, like make sure that we're limiting it to trying to deduplicate the data and processing it to flag certain things. So it's not doing the text analysis. So then it pulls less visits because it's only by diagnosis codes, but it allows us to look at other things like cannabis hyperemesis syndrome. So that's the benefit of it. But it's not. So there's just a difference. They're both syndromic, but with the hyperemesis data, the reason why like the totals that you might see in that spreadsheet are different from the totals you'd see in the other one is just how they're being pulled and analyzed. And so I just want to make that clear. And so if folks have extra questions about like how we should write that up in the report, if we end up using some of those diagnosis specific data, I'm happy to like write something up for that.
I think we should use diagnosis specific data wherever possible. I think that that's a lot of the compelling data that's coming out of Colorado and some of these states that sort of have the more mature markets. They're talking about, hyperemesis, their child exposures. I don't know if there's enough data, like a robust enough subset for cardiovascular risk, and then psychiatric presentations seems like the other major diagnosis that I've seen some of the literature on. So I think that pulling out some of these major diagnoses that are of concern is really valuable. Thank you.
Hallie.
Just a quick question. Are there ways to pull out data by other groups? So for example, if, I don't know, Native American or people of color or some other diversity oriented groups, just to understand if there are differences in, say, ED use or other data.
Yeah, so that's another thing where the process data, I think, is a lot easier for me to pull those kind of demographics. It is technically possible in the Essence side, but it's a bit cleaner, I guess I would say, from the process data. So yeah, if we're wanting to look at things like race, ethnicity, or by county, my recommendation would be to use the process data, but then there is a larger delay on it. So when I'm processing data, I get it on a quarterly basis, and I have to wait usually about 2 months after a quarter ends before I can run it for deduplication and all that. So there is more of a delay in it compared to the Essence platform data, but I think we end up with sort of higher quality data in a way once have the opportunity to process it and sort of segment it out that way.
So just as a quick follow-up, are there holes in the data that we can clearly delineate also? For example, do we get information from the Indian Health Service?
Right, that's a great point. Yeah, and that's one of the footnotes in all of the spreadsheets that should be included there, is that we do not get federal facility data at all. So nothing from Indian Health Services and nothing from like the VA, for example. So yeah, that's definitely an important note to make in any of this.
Okay, great, thanks. And Katie, welcome. Good to see you. So number 5 is, of course, educational needs for children and adults. And Katie and Crystal and I talked a little bit about this yesterday. One thing we are waiting for is, of course, the YRS data. We'll probably use the 2023, the 2024 will not be out. But another theme that sort of, again, as we were talking about common threads, is that number 6 is the consumer product and safety. And one of the advocacy points there was talking about packaging and labeling. And I almost think that that could actually work under the educational needs for children as well, because there is plenty of product safety items to be discussed. So that hasn't been really drilled down, but those are 2 things that the group number 5 had been considering. Group 6, Eleni, I think that you mentioned that you would, be our spokesperson for the consumer and product safety. I think you and Alan and I had met previously, and I hope I'm not putting you on the spot. I do have the talking points here if you want me to talk about those, but again, I'll let you take it from here.
Yeah, thank you. I think we had a really good meeting recently when I think it was the 27th that we met. So we talked about how high impact this section could really be in terms of important issues that are coming up from a public health standpoint. We talked about how some of the issues surrounding testing and how the testing might not quite have caught up with the licensing and manufacturing, and that's my understanding from what you were saying is that there are 2 private labs and a state lab that are doing some of the testing, but that we haven't had access to the specific data that they're doing the testing for. The regulations indicate that the product is required to be tested for both potency and for contaminants. By law, I think it's microbes, pesticides, residual solvents, as well as water and soil testing for heavy metals. But we haven't been able to see the results of any of those tests. And so I think sort of the 3 issues that we maybe could touch on in this section would be potency, contaminants, and then, as you were saying, packaging and labeling as well. We have some information from the CPPC survey data. Most of that is sort of around participants' perception, although there's a really interesting section on potency, which I was actually going to touch on prior to the journal article discussion. And so I think that's where most of our available data is right now. But I see hands up, so please correct me if we have ideas on how to move forward with this. Hallie, I see your hands up first.
When you say we can't get our hands on the data, are those data in the state, or those data that are from the commercial entities themselves that do the testing and don't have to report to the state, or how does that work exactly?
Andrea?
This is exactly where I had my hand. So I believe we can actually pull the testing data from BioTrack, from the test that anytime product is tested, the test report has to be submitted to the system to show the product is safe. And a label is created. So we can actually pull that data. Now they have just recently implemented the pesticide testing. So that actually just started. And you may have seen in the news that there was an agency that they had some product that they were selling that they had originally tested in 2022 when they did not require pesticide testing. They said, hey, we want you to retest this because it's so old. And the acceptable level for the specific pesticide was 0.03. And first lab tested it, it was 30. Second lab tested it, it was 60. So they actually said you can't sell that product, pull the product, and there's now a lawsuit pending against Cannabis Control Division for saying they can't sell that product. So it's very interesting. We have pushback from producers about the testing, but we can pull some of that testing data from the traceability system to see how many are failing, what kind of contaminants they're finding in products and things like that.
And here's the news release from the RLD with regards to that, exactly what Andrea was talking about. And this is what we used as a springboard for our conversation the other day. So it's there in the file, if you guys, in that folder, if you are interested in reviewing it and looking at it. And I'm glad to hear that, Andrea, because again, when you go to CCD's website, it says, and we looked at it, it's just like yet to come or being developed with regards to them reporting that data. Because again, I think that there are patients that are rather fastidious and would look to see, well, where is my cannabis and where does it rank on the system here, and what is the testing showing? And it's just that, you know, and maybe that's the talking point as well, is why isn't this data more forward facing for patients to access? But yeah, it's there if you're intrigued, and I think what we'll do is try to find out how we can perhaps pull that data, make it available to you, since I don't necessarily believe it's going to be as available from RLD in the near future. So next,
well, and I do want to kind of piggyback on that. One of the things I do want to say is that it is actually not RLD's fault. There are there's pushback from the licensees, because they're saying like, hey, wait a minute, you can't put that because that's going to make us look bad. And because we can go back and remediate these products to get them to an acceptable level. And if you're saying that our products are bad, then, you know, that's going to affect our business. So that's why that has been pending for so long, is they're trying to figure out the legal argument of why we should be able to post that. We said it's comparable to like when they do health inspections at restaurants, but so far that argument is being looked at. So that's where they are with that.
So, sorry, just to follow up, I don't quite understand the process here. So there's a contaminant that's found, that's in a lab. Does the lab have to report that to the state?
Yeah, it's automatically reported and the product cannot be sold. So anytime they process a product, it gets a specific barcode. That barcode is applied for the testing. And once it goes through that testing, if it does not pass testing, that agency cannot sell anything related to that barcode until they can demonstrate that if the problem's been corrected, or if they haven't retested to see if there was a testing error or anything. So they actually cannot ring up that product in their actual sales system.
So then the issue here really is what becomes public as opposed to because it's technically off the market at that point.
Correct. Yes.
Yeah.
Until it's corrected. Yeah.
Do we have any information as to whether, in fact, they do take them off the market, or there's compliance?
So they can't actually sell it. So what I don't know that we could do is like, so a lot of these labs and producers they'll take a product, they'll test it and say it failed for like bacteria or something, and they send it back and they somehow remediate it, and then they'll send it back and have it tested again and it will pass. So it's under the same barcode, but now it's passing. So there's a lot of questions about how that's actually occurring. So it's, yeah, what we don't have, I may not have is data on that, but we can pull data to see how many times product is failing testing for contaminants.
And is there any agency, whether it's RLD or whoever, that then does spot checking to make sure it's compliance and that there's no collusion between the labs and the commercial entities, for example?
Oh, I'm shocked you think there's collusion. I will tell you that has been an ongoing. No. That has been an ongoing concern, not only in our state but other states. That people will take product to one lab and test it, and it fails. They take it to another, and it passes. So our state lab division is the ones that inspects and authorizes all of the labs. So when they have to make sure that they have proper processes in place for conducting these tests. And RLD is Cannabis Control Division is trying to get more staff that they will then be able to go and get product and actually take it to the state lab division to test it. But right now they just don't have the staffing to get that all done. And they are doing inspections. They're doing surprise inspections, but with over 1,400 locations, and I think they have 5 inspectors at this point, it can be very challenging for them to be able to do that.
Sure. Thank you.
Eileen?
Thanks. So there was a lot of information there that was so important. Thank you so much. Yeah. What I wonder about is if the committee would like to have maybe at a future meeting a little bit more doing a deeper dive there. Is that Andrea? Does that sound like Gary? Does that sound like, and other committee members? Does that sound like something that that we would like to better understand and spend our time together on? I saw Andrea. Okay, good. Okay, thank you. Thank you. And
yeah, we can put something
which...
together for the next meeting just to kind of talk about the process of like what the product actually goes through. And, you know, we could perhaps talk with Cannabis Control Division to find out what they're doing about inspections. Like I said, bless their hearts, they're like any other state program. They just I don't know if they just didn't anticipate how many locations there were going to be. But they just requested more funding this past session to be able to hire more inspectors. And the really nice part is they're actually going to let our agency kind of piggyback on their inspections.
Nice.
So we can go out and see how they're actually treating medical patients when they come in, and are they charging a different price for medical patients as they are recreational for the same product.
Nice.
So we're trying to get all done, but as you can imagine, it's a lot of coordination and policy development. So,
of
we
course,
can put together
yeah.
something on that whole process. So,
yeah, thank you. And I think that maybe what we could decide is, if it sounds okay, and then next is that that we'll all learn a little bit from you, and then we can decide how best and if to reflect those challenges and some opportunities that include an ask into our report. How does that sound? Okay, yeah. Thank you. Eleni, I hope that got to your question in the chat as well. And thank you.
I think understanding the roles of the private labs and the state lab and how they perhaps will interface going on will be helpful and useful. And I think that could definitely be a great theme for a meeting. Holly.
Just one additional thing, we might consider also having somebody from the industry talk about what their concerns and barriers are, just so we get a sense of how they're interacting with them, not solely from the regulatory side.
Well,
can I better understand? Yeah, if that falls under our charge, because I think as people and as scientists, that I think is really important. I'd like to. I'm going to think a little bit more about our charge to make sure that that it's not seen as whatever our report is that there's not any undue influence of
sure,
of industry.
The perspective of those who are interacting with these folks, so we could still get the information that Eileen, you and Andrea were talking about earlier, and then see, all right, so what are some of the other issues that you may be encountering that we don't even know about?
Yeah.
Well, if you go to here are all the regulations that industry members would have to follow. So you can actually read through and understand what the industry would be required to do. And this is found in the file folder there. And so this is the regulations that would guide them. So that might be also a place where we can get an understanding of what industry folks might be going through. There's that there. And then here is our other regulations. These are the ones with wrong one. This is packaging and labeling. But again, with regards to testing, I would say that we could definitely review this first and foremost to understand, and then that would also sort of put whatever the industry did share more into context if we are able, depending on what we do there. So real quick, because we do have Eleni's journal article, the percentage of Poison Control Center calls. Katie, Crystal, and I had a great meeting yesterday. We talked about, the role of the Poison Control Center. And one thing is there was a really great article that Katie had here with regards, it was a review of 37 different other, it was a systemic review. And so that's there for review. And I think one thing to glean from this is that what New Mexico is going through, other states are going through as well. That, maybe just sharing that, this is not unique to New Mexico is something that we could talk about. But then also, in speaking with Haley, there is a dashboard, a poison control dashboard that, by chance of a grant funding is still around to be utilized. And again, we might want to highlight the usefulness of the dashboard. Haley, did you want to share one or two little tidbits more about the need for the dashboard and how, this might be something the legislature, again, this thread of children, they might really want to keep this in the forefront?
Yeah, so I think we've talked a little bit about the Poison Control Center data before and how we've been angling to try to get a dashboard created there. We've tried before to include it in sort of expansion requests for Department of Health to get funding from the legislature for it. That hasn't been successful in the past, but just by some luck, we're hopeful maybe on one of the grants that I work on from CDC that's for overdose data, that we may be able to get some cannabis data funded in a dashboard of the Poison Control Center calls by making it a substance use dashboard. So making it more broadly applicable to that grant. It's still a maybe, so I don't know that it'll happen, but we're hopeful that maybe in our next grant year, which means it wouldn't be until September at the earliest when we could even consider starting the contract process for that. So it wouldn't be ready by the time of this report, but we're still hopeful that we might be able to get that done. But because it's a maybe, I still think we really need to advocate for funding directly from the state for this project, because there will also need to be maintenance of this dashboard, because we'll want, of course, that data updated regularly. And it'll be really valuable. We've talked with that group several times now. Our Poison Control Center folks are great here in the state, and the folks that they're working with who would actually create the dashboard for them, they made a mock-up for us. We'd be able to look at product type, age, what ended up happening with the caller. Like, did they go seek healthcare, or did they handle it at home? That kind of thing. So it would be really valuable, because then instead of you all having to wait for me to find time to pull data from their system and analyze it and all that, instead it would just be up on a website, like ready to go, exactly how you need it. Whereas right now, unfortunately, this isn't my only thing. And so a lot of times it's being juggled among a lot of other stuff. And so I think it would just be a huge help for this group to have that readily available and frequently updating, rather than just being like a quick data pull when there's time. So yeah, I think that would be really valuable. And then I'll just make another plug that I think we still need to advocate for there to be an actual cannabis epidemiologist at the department. I love working with you guys and I love working on this data, but but again, I think if you guys had a dedicated epi that only worked on this, you'd probably get a lot more of what you wanted, because they wouldn't be juggling it with the other stuff they're actually supposed to work on. So I just want to always plug that, if the legislature is expecting these huge reports from us, they should fund the work that makes it, in my opinion. But maybe I shouldn't be saying that on this call. I don't know.
No,
I was going to say
that
the
might
same
get me in
thing, so
trouble.
you're fine. You're fine. I was going to say it, so we'll just say that I said it.
And again, this is another article that I dragged in there. Again, poison control centers, but again, we talked a little bit about the mental health aspect of it as well. And here we could have a dashboard that doesn't just follow kids, but follows all these other items as well. And here we go, suspected suicidal cannabis exposures. Again, this is a database that I think the legislators would, maybe they wouldn't access it themselves, but them knowing that it's there and available if they, did need to access it. Again, just elevating this in the mind of people. And if anything came from this report, this dashboard would be, a phenomenal addition. Eileen.
Oh, I was just going to say that if it, maybe we can have, if for to whatever extent that we have our own recollection or minutes or however it wants to represent, I'm very happy to be the person to say, wow, it really sounds like if we're supposed to be developing these sorts of reports, that there should be a dedicated epidemiologist and that this should be a dashboard with funding for its creation and its maintenance so that we can all do our best work to take care of New Mexicans in an evidence-informed way. How's that, Haley and Andrea?
And just,
Hey,
Yeah,
and just
that's exactly what we need is we need to like start letting them know like, hey, we want this data as well. And you know, if you want us to collect this, it's grant funded. And we always know with grants, while we keep that funding's there, you don't know really from year to year. And you know, and as much as we enjoy working with Haley and appreciate everything she does for us, which we really do, you know, we'd like to be able to have somebody that could focus on it, you know, that would be helpful. So yeah, I if we could use the report to justify positions and funding and, you know, so we can get better at what we're doing, we're all for that.
And just to close out real quick, so we can move on to the next section there. Number 8, again, we're talking about the impact of cannabis use of rates on alcohol, opioids, and other substance abuse. And again, that interface, I'm not so sure we have huge amounts of data there, but we do have our CPP surveys. And again, we've been asking questions. We have another survey coming out in 2024 where we ask a little bit more about that. Again, we're not condoning patients utilizing, cannabis to decline the use or decrease the use of these other substances. But what we found out in questions is that patients are doing it and not necessarily with the attention of their providers. So again, I think as we have more surveys, we'll get a better understanding of this intersection of cannabis use and reduction in other substances. And that being said, I just tie that up and hand it back to you, Eileen, or to Eleni, if you want to segue right into the journal article. But yeah, lots of great discussion today.
Lots of great discussion. We're near the top of the hour. It does look like I think that Kathy's hand is raised. But I'm not able to hear you. Are others able to hear Kathy? Kathy, would you maybe
How is this better?
Oh, much better. Thank you.
Much better. Okay. I have to jump off to another meeting, but I just wanted to do a quick poll to ensure that everyone on the call is able to successfully access the SharePoint site where these resources are located. Seeing some heads nodding. Yes. Okay. All right. If anyone by chance not, please feel free to reach out to me. So, thank you. You're on mute, Eileen.
I was just talking to myself. That was an incredible conversation, and just I think that the work that people have done to advance, you've all done remarkable work here, and thank you. And I think that the amount of the progress that has been made in such a short amount of time and sort of help narrowing the focus, right? Because we can do anything we want, but we can't do everything if we want to be successful. So this is really remarkable and also strategic. With that, then I'd love to turn it over to Eleni to continue to learn from her and her journal article review.
Thank you, Eileen. Now for the part where I figure out how to share my screen. I don't know that anything happened.
So we don't see your screen. Oh, there you go. It's starting to show.
Right.
And I'm just going to interrupt for 1 second. I do apologize. I got double booked. So I have to step off for a meeting at 11. You're in very good hands, but if there's anything I can do to help you guys on this process, please feel free to let me know.
Thank you.
Thank you. Are you guys seeing, does it look like the slides are fully filling the screen like they're supposed to?
Yes.
Okay, excellent. So all I can see is my slides right now. So just feel free to jump in if you have a question. I was going to talk about a couple of things that came up when I was doing this reading that I thought were really valuable. everyone on this call is a content expert. So if I'm saying something that's inaccurate or, you know, if you have more to add on the issue, please feel free to jump in and correct me, add thoughts, anything valuable. I thought it would be interesting to take things a little more in the consumer and product safety direction, because we've talked some about pregnancy and child access. And I wanted to talk in particular about dosing and some of the issues surrounding the higher potency and diversity of cannabis products. So I thought this was really interesting. We ran out of time at the last meeting kind of talking about the Cannabis Public Policy and Consulting Report, but this part really struck me from the report. It's on page 10, and they were actually able to calculate the median THC dose in milligrams per occasion by method of administration for the survey participants. So this table on the right is the median THC dose that they calculated that our consumers are actually using. And then they had the sentence in there: currently scientific literature proposes a standard dose of 5 milligrams of THC for safe consumption. Therefore, participants may be consuming higher doses of THC than necessary. And I was really struck by the discrepancy between a standard dose of 5 milligrams and these much larger doses that they were reporting that folks were using. And so I wanted to see sort of where that 5 milligrams was coming from and kind of look a little bit more into that, because it seemed like such a large discrepancy. So the two references that they had from the report, which were really valuable, the first was from this NIDA publication, Nora's blog. It's by Dr. Volko, who's the director of NIDA. And in this post from 2021, she's highlighting a notice that was published in the NIH guide for researchers who are funded by NIDA, the National Cancer Institute, the National Heart, Lung, and Blood Institute, and the National Institute of Mental Health. And they have been instructed to measure and report their findings from clinical research on cannabis using a standard unit of delta-9 tetrahydrocannabinol THC of 5 milligrams. And they are saying that this is not a suggested standard dose for consumption or applying to consumers or dispensaries. It's simply a unit of measure to help facilitate cannabis research, saying that this dose may produce a high in both experienced and occasional users, but is unlikely to have adverse effects. And they primarily reference, in coming up with this dose, this addiction article from 2019 by Freeman and Lorenzetti, where they propose a standard cannabis unit of 5 milligrams. And they're saying, you know, because there are a lot of different ways that you can express this, and they're saying that similar to alcohol, standard cannabis units should reflect the active pharmacological constituents. It's like a shot of vodka is smaller by volume than a pint of beer, but it contains the same amount of alcohol that will affect the consumer. And so by milligrams of THC, they think that that's sort of a way to do this similarly. And they cite a number of studies as coming up with this as a meaningful standard dose while being low enough to minimize risk of adverse effects. So they cited a study that inhaled and oral doses of THC ranging from 2 to 8 milligrams can have intoxicating effects without producing severe adverse effects amongst infrequent users. And they note that although frequent users can develop a tolerance, 8 milligrams was found in a study to produce robust subjective cognitive and psychotomimetic effects in daily cannabis users. And then they, in terms of adverse effects, there was a study where they administered 10 milligrams of oral THC to participants who had had minimal exposure, and 33% experienced a severe reaction such as paranoia. And a second study administered 25 milligrams of THC to participants who had not used cannabis in the last month, and 12.5 of them experienced vomiting. So they thought that the 5 milligram dose was less likely to have adverse effects. And they are actually suggesting that this should maybe be applied from a consumer standpoint. They're saying from a public health perspective, it may be advantageous to choose a standard THC unit lower than the average level of consumption, which could encourage folks to consume less THC and reduce the chances of an unpleasant response to a single THC unit in naive volunteers or presumably first-time users. They also note that the risk of unintentional or excessive dosing is especially high for edible products because there's slow onset of effects, and said that as of the time of the publication of this article, which was in 2019, the maximum quantity of THC that could be sold in a single serving of edible was limited to 5 milligrams in Alaska and Oregon and 10 milligrams in Colorado and Washington. And in Canada, it was limited to 10 milligrams of edible per package. In case you're wondering, New Mexico, the limit is 10 milligrams of total THC per serving, or 100 milligrams total in a package. And with the exception, and Gary, correct me if I'm interpreting this inaccurately, but with the exception that for medical use only, the dose can be up to 50 milligrams of total THC. So this was the article I wanted to discuss. It doesn't have, it's a little bit different from prior articles in that there isn't a lot of data presentation. It's more of a review of some of the literature that I think is really relevant, and they make a few recommendations from a public health standpoint, incorporating some prior recommendations and reviews. And I thought that that would be relevant to our work here, at least as a point of discussion, not necessarily as, you know, this is absolutely right or wrong, but I think it's very relevant to our work as a committee. So this was published in September of 2020 in Frontiers in Psychiatry by Matheson and Lafole, who are Canadian, and it's Cannabis Legalization and Acute Harm from High Potency Cannabis Products, a narrative review and recommendations for public health. So they start off with sort of a literature review discussing some of these issues, saying while there is a potential for net beneficial effect of legalization of non-medical cannabis, there are concerns due to increasing potential for public health harms. There have been a lot of challenges in conducting epidemiological research, and so the long-term adverse health effects of cannabis are largely uncertain. Some of the long-term health effects, in addition to the psychological effects, for which it is difficult to establish causality, but there are concerns for decline in cognitive function, psychosocial impairment, decline in educational vocational impairment, and the possibility of psychotic symptoms or illness and cannabis use disorder. And then there's some concern for elevated cardiovascular disease risk, possibly testicular cancer, cannabis hyperemesis, and then respiratory issues as well. They note that the acute harms have been less well studied, in part, I think, just because we've had less time to look at that. The primary areas of deaths which are related to cannabis would be motor vehicle collisions. There are some case reports of deaths from cardiovascular events or cannabis hyperemesis syndrome. And then really concerning is the psychological consequences. And I think that this has gotten a lot of attention and exposure in the press. While the acute harms remain low compared to harms associated with alcohol and other illicit drugs such as heroin and methamphetamine, they note that with legalization, there's the potential for some of these harms to increase because with the emergence of the legal market, there's increasing potency and diversity of the products. Existing users may increase quantity or frequency, and new users may be attracted as well. So they wanted to discuss some of the concern for acute harms and then what might be done to mitigate that. So there have been two major changes in the products available to consumers as the legal markets have emerged. And the largest impact changes are the increasing potency, the increasing THC potency of the cannabis, and the diversity of products available. So the potency of cannabis has been increasing over decades. Potency is typically quantified as a proportion of THC in a cannabis product. However, that can also sometimes include levels of CBD, which has been demonstrated to offset or reduce some of the negative impacts of THC. And in general, cannabis with higher proportions of THC is generally considered more harmful, but the increasing level of CBD may mitigate some of that. And it's very clear to see that the THC potency has been increasing. A few decades ago, the global mean THC potency of cannabis was approximately 1 to 2%, but there's been a tenfold increase in potency of dried plant material between 1970 and 2009 worldwide, and the mean THC potency in the US increased from 8.9% in 2008 to 17.1% in 2017. The graph on the right is actually not from this article, but I thought it really well demonstrated this point. This is from the NIDA website. And you can see that the CBD is pretty level, but the THC percentage has increased substantially over the last 25 years. There's also an increase in the diversity of cannabis products. We're seeing these unprecedented products and formulations. The ones that they touch on specifically are edibles, which can have a delayed and unpredictable onset and duration of symptoms. They noted a study that was a survey in Colorado that edible use was associated with greater odds of experiencing an unexpected high. They've talked about concerns around vaporized cannabis and concern for injuries and deaths associated with the use of those vaporizers. And also these cannabis concentrates, these very high concentrated THC, the waxes, dabs, shatter, which are commonly used for their greater drug-induced high and have been associated with a number of acute harms, including acute psychosis, cardiotoxicity, and respiratory failure. These images on the right are not from the article either. They are screenshots that I pulled from a couple of the local dispensaries' websites, just of products that are available for you to buy. And you can see the text is a little bit small, but you can see sort of how high these THC concentrations are. In the 80s, this vape concentration is up above 90. So this increase in potency and diversity is concerning because it challenges the generalizability of previous studies around acute cannabis-related harms. They're not really applicable in the current market. They note that research conducted in the United States is actually limited to using cannabis produced by NIDA because that's the only federally legal source of cannabis. So if they're using any sort of federal grant funding, they have to use this cannabis. And there was one study that found that's nearly a quarter of the potency of cannabis available in the legal retail market, so substantially smaller. Most of the placebo-controlled studies of acute effects have used dried flower as opposed to these concentrates or edibles. There are very few studies on the effects of edibles, and virtually no controlled studies have assessed the acute effects of like these concentrates and the other really high potency products. There are some epidemiological studies that have demonstrated associations between higher potency cannabis and risk of cannabis use disorder and psychosis. Specific associations with acute harms are less clear. There's just not a lot of data, unfortunately. I did, just as a side note, I did read a really interesting but very long article that was sort of out of the scope of this presentation. That was a systemic analysis of mental health effects associated with acute or with high potency versus low potency cannabis. And it was really interesting because it brought together sort of, they went through a lot of studies and brought together sort of 20 studies that they seemed sort of would reasonably apply to this. But all of the quality of the studies was either fair or poor. They said only a third of them even set out to like look at potency in the first place. And a lot of what they're doing when they're talking about high versus low potency, I think at least half of the studies were comparing hash type versus skunk type cannabis, which I guess is the difference between like 5 versus 11%. So that's not really even applicable on a market where I was reading on one dispensary website that they don't even sell anything that's under 10%. And a lot of these concentrates are up at, 80, even 90%. So they made some recommendations to try to minimize some of these acute harms. They made the point that legalization without restriction can potentially be just as harmful as prohibition. So the recommendations that they made based on, a couple of sort of their thoughts on looking at the data and also some other recommendations from some other review articles were early restriction of edibles and newer products for which less safety data is currently available. They recommended proper labeling of cannabis products that clearly and consistently communicates dose and serving size as well as health risks, and also a robust framework of data collection to monitor harms associated with cannabis use, which should ideally be broken down by consumer characteristics and product type to help stratify that risk. So they talked a lot about some of the concerns surrounding edibles. They talked about some of the data coming out of Colorado, which I touched on a little in the first article I reviewed, which was written by that emergency physician in Colorado. They show that trying new cannabis products and edibles was associated with the unexpected highs, and the unexpected highs often led to acute psychological harms such as paranoia, panic attacks, hallucinations, and ED visits. There were also concerns with the edibles for accidental ingestion by children. I know this is a huge issue that we keep talking about. And there were a few, unfortunately, high-profile deaths, which had a lot of media coverage and were associated with edible use shortly after legalization in the Colorado market. So Colorado created a task force to try to address some of these safety issues, and it did lead to tighter regulations and stricter packaging requirements. The authors of this article argue that data from both Colorado and Washington favor early restriction of edibles and high-potency cannabis products to give the market time to stabilize and for data collection systems to be implemented to allow for basically more data on what these products are going to do in some more placebo-controlled safety trials. I know that cat might be out of the bag a little bit from that standpoint in terms of our market, but in terms of the regulations and packaging requirements, Gary was able to send me the regulations on packaging and labeling, which I think are both on the SharePoint, and I put it in the product safety tab on Zotero. And I was actually really impressed by how tight this is from a New Mexico standpoint. It's a 7-page document, and I think they've really done a really good job in terms of safety labels and what exactly has to be on there. It's really impressive if you guys want to take a look at it. The review notes that consumers often have very little understanding of product labeling information, and they sometimes have difficulty interpreting doses expressed in milligrams. And it's also compounded by the fact that the same dose of THC is not necessarily comparable across multiple routes of administration. Like 5 milligrams is an edible, and then you're trying to compare that sort of to 5 milligrams of using the dried flower versus, a vapor concentrate. It's surprisingly complex and kind of difficult to understand. And so what they are suggesting is that products be properly labeled with clear information on dose and potential harms, that requires minimal numeracy to understand. They suggest a standardization of dosing or servings that does not exceed the typical amount required to become intoxicated. So that's where sort of a discussed standard dose would be relevant. Clarity of dose expression on the labels, packaging that reinforces the label information. So basically a dose that's the same as, like, it's packaged in the same way as it's packaged to be one dose. The labeling can provide comparison across products. The need to deter packaging, need for packaging that deters children, and clear universal symbols that indicate a product contains cannabis, as well as a need for consistent product testing to ensure that dose and potency information on the labels is accurate, and that there need to be universal testing standards. Interestingly, they cited a study of state certified labs in Washington that found significant variability between the testing facilities, with some facilities consistently reporting higher or lower cannabinoid concentrations due to systemic differences in their testing methodology. So that would be really relevant for us when we're talking about sort of these different labs and the testing and how that's impacting the market. And then they say that the label should convey health messages associated with risks, and they should be pictorial or have minimal text. So this is, again, an image pulled off of a New Mexico dispensary website, and I thought that it illustrated a couple of these facts. You can see that there are 10 milligram gummies per pack, 100 milligrams of THC total, which is very clearly laid out, and then this symbol that clearly indicates that there is THC in this product. And they recommend a robust data collection to begin to monitor the harms associated with product, and to be able to break that down by consumer characteristics and product type. So they recommend collecting information on product type, on potency, on route of administration, on consumer characteristics, and they want to be able to, ideally identify the higher risk populations and consumption patterns. And they suggest that this data would be pulled from multiple sources, but that it should be integrated into a single system to allow for monitoring of impact. So they mentioned ED visits, poison center calls, and federal and state surveys, all of which are data that we've talked about incorporating into the report. I don't know if consumers are reporting to the producers of cannabis, or if we have any access to that data. That's an interesting thought. I think these are areas where we are already looking at a lot of this data. We definitely don't have a single regulatory system, and that's very challenging when we're sort of doing things on a state-by-state basis, probably. And so they talk about some of the challenges, lag time between implementation of policy issues and the availability of data. And I think we've talked about this issue a lot, that the ED and poison center data, especially the ED and hospitalization data, doesn't collect details on the cannabis product information. So we don't know quantity, potency, route of administration, and that information would be very helpful in terms of figuring out these acute harms. So this was my last slide. Thank you. I'm going to stop sharing, and does anyone have any questions? Hallie.
So I've got two. One is more generic, since this is a great article, and I'm really glad that you brought it to our attention, because I think it summarized a lot of the issues that we've been talking about for so long, and it should be very helpful for putting into our report. I guess one of my questions is, since it's from 2020, is there anything more recently that could either add data to all of this, so that we now can confirm or deny some of their statements, number one? And the other type is, you mentioned that our regulations are pretty tight. were you able to do any comparison of their suggestions versus our regulations, and how compliant are we with some of those suggestions that they're, or consistent are we with some of those suggestions?
Yeah, great questions. To answer your first question, there's a lot of different areas to focus on from a public health standpoint. That article that I mentioned that was looking into some of the primary literature surrounding the high potency cannabis was from 2022. And I uploaded that into Zotero under the product safety tab as well. My impression just from looking through a lot is that we still don't have placebo-controlled trials or robust data, especially on the high potency products, unfortunately.
What about the data from states that could update what some of the stuff they're doing?
I think most of that is coming, like the best data seems to be coming out of Colorado in terms of the acute harms. I didn't see anything that was really striking as in the last couple of years, but it's remarkable if you go on PubMed, there's this huge spike just in the last couple of years of publications relating to cannabis. There's a lot I think there were like a few thousand articles just from the last few years. And so there's definitely more to go through, and I will definitely keep reading and looking.
Thank you.
Of course, and then just to answer your second, or Eileen, did you have something that, Eileen, did you have something that relates to that point specifically?
I can wait till you're done. Thank you.
Okay. I was just going to say that in terms of the packaging and labeling recommendations, I actually started to do slides on it, and I realized that it was going to be too long, that my presentation was going to be too long. But I do think that there are excellent requirements for clear labeling, for the doses to be standardized, for there to be an indication that there's THC on the label. Opaque packaging that is supposed to be child resistant is mentioned as well. Clear universal symbols of the product contains cannabis. And then labels regarding health warnings are also something that New Mexico has implemented. Now, I don't know that just because those regulations are there, it doesn't necessarily mean that all the products are compliant with them. And I don't know that we are able to tell. There was at least one product that I pulled up on a website where it said 10 gummies, 25 milligrams of THC. And I was like, well, that doesn't seem like it goes with the regulations unless it's like specifically targeted for medical patients. So I don't know how compliant the products are with the regulations, but I think from a packaging and labeling standpoint, the legal regulations that have been laid out are really very well done. Eileen?
Eleni, I thought that was really remarkable, and I wanted to maybe reflect two things. One of them is that I do hope that all the work that you put into that there are other venues where you might be able to present that, because I think that a lot of the I think a lot of healthcare workers probably don't know that information, and I think a lot of just the public doesn't. In addition to our citizen legislature, that there's just a lot more nuance, and I think that people have possibly understood. While you were speaking, I was also reflecting on how this morning I saw an article in the New York Times about how labeling for safety for alcohol, and how few people actually understand it, and most people don't know that alcohol in the United States all has a label for safety, and most people don't know, and that it's on the back of the bottle, and that the way that it's written, it actually people don't even they don't pay attention to it, versus labeling that can be with that's sort of straightforward with a photograph. There's different ways to do so, and it was just very striking to me to think about how humbling all of these different articles have been for finding that the issue is a lot more nuanced than possibly the legislature had understood, and then a lot of patients, the public, and healthcare workers understand about risks and benefits. I find myself really compelled by how the example that you showed about the what was it? The title was some catchy name like Reefer Gladness or something. But also how that was really catchy, but also like that looks like candy in every way, shape, or form. And if anyone wanted to really say that they believe in access, with safety is it would be that it cannot look like candy in any way, and that the packaging can't be like these pastel colors. It's really, really interesting. It's like the example of like a Tylenol bottle doesn't look exciting, right? And carrots don't look exciting. They just look like what they are. And so it makes me think about that we might find ourselves in a very different regulatory environment if we decide to take a true public health approach here, and have something that looked nothing like that it actually could taste good.
They all look like that.
I'm sorry. Yeah, I don't mean to go after that one. Yeah.
No, I was just like, yes, you are right. The whole inventory on the whole website looks like that. I feel like the green chili gummies on the prior slide were even worse because that doesn't even have a thing that says like THC in the, you know.
Yeah. Yeah.
They all look like that.
Lots of great stuff here. Yeah. I'm going to lower my hand here. I don't know if anybody else has any questions, and I know that people are really sensitive to that. We're getting to the bottom of the hour. And I think, nice. I mean, I don't like broccoli, so I think that that's perfectly fine.
I agree, Haley. Less colorful labeling is a really, that's a really interesting idea, and that is not something that's in the regulations.
You know, it might be if they all had to look like broccoli, we could achieve two things. One is, of course, avoiding it, but then in the future, you know, we might get kids to actually like broccoli, and so maybe we'll start eating more nutritionally too. So it could be either way. I don't know. I haven't thought it through. This was just off the top of my head. I did have one other question now that got diverted by broccoli, so I'll see if I can remember it before we're done.
Any other questions, comments, corrections?
I think probably just our abiding admiration and gratitude. Very, very nicely done. Truly, truly, truly.
Thank you.
Yeah. Team, I think coming up to the 5 minutes left in the meeting, notice that I got 2 minutes ago or 3 minutes ago for other business. I know that we did already come up with one item of other business that Andrea is going to present on next time. I wonder if we can maybe follow up offline if anybody has any other business that they'd like us to introduce, and maybe think about what our next meeting can be. And thinking about our habit of our Tuesdays, I'll ask if on, goodness, I know I can't make it on June 11th, which is 2 months from, 2 months in the second Tuesday. So I would ask about a consideration for the first Tuesday, June 4th, at the same time.
I'm going to be out of state.
Okay. How about the 18th then? Thank you. Gary, I saw your eyebrows go up, but I don't know if that day works for you.
That would be fine.
Okay, wonderful. And I'm trying to look because I think otherwise my view is that maybe I'll ask anybody to speak up if that date and time don't work for them.
What's the date again? I'm sorry.
Forgive me. It's Tuesday, June 18th at 10 a.m.
Yeah, I'm likely to be out of the country then.
Good for you.
I don't know if I could get on by Wi-Fi, depending on what the circumstances are at the time.
Okay. Do we want to try the 25th then?
That would be much better for me. The 25th is oh, I'm sorry, I'm looking at July. Just 1 second. June 25th is about the day I'll be returning this from what I can tell. So I don't want to hold the whole committee up. Earlier in the month, like the 4th would have been better from my perspective, but
okay, I think where we might be landing is that we might not have a date where everybody is able to.
I don't have to, you know, you don't have to work around me either. I'll be in Hawaii. I don't know if I can get up at 4 in the morning to do a meeting, but that's, you guys can make that one too.
I would ask you not to. And just to enjoy it. Maybe Gary, I will ask you of what of those dates that you heard is best for you. Or we don't, I just know that I can't make it on the 11th. Maybe everybody else can, and we can just have it without me. Gary, how about you? Would you like to be our tiebreaker?
Oh, I'm fine with all of those. So I'm sorry that doesn't help, but yeah, all three of those work. The 4th, 11th, or the 18th.
Okay, then maybe we'll go back to the 11th, and I'll see what I can move. Does the 11th work? Or Eleni, are you back on the mainland, and Haley, are you not yet out of the country?
No, that's the day I leave, actually, so.
I see, okay.
I don't have my flight yet, so I don't know what time. It's possible in the morning, but I don't have that information yet, so.
Okay. All right. I'm going to, hold on. Siri, choose a random number between 1 and 4. Okay, Siri chose the 18th. Is that okay? Okay. All right, so we will do the same time on Tuesday the 18th. And that, Haley, I'm sorry that, I hope that you're able to join us despite, and I hope that it isn't, I hope that your travel is north-south so that it's not too time zone disruptive.
We'll see how it works out.
Okay, thank you. Okay, thank you, everybody. Really remarkable work between the meetings and today in the meeting. I'm grateful to all of you. I hope that you have the rest of the week that you deserve. Gary, any other closing thoughts for us?
Did we want to have a journal article for the next meeting, or just rely on the sort of the lab industry?
That's a great question. I have felt that the journal articles have been remarkable, knowing that we did this time run over, and that was remarkable time spent, but I think we'll have more updates on the reports also too, that maybe we'll do a hiatus for this time and see what happens. We'll probably come back to it for the next one. Does that sound okay, team? Okay, all right. Thank you for being understanding. Fantastic work. Have a great day.